All right, welcome everyone to the Special Populations Core 2022 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thanks for joining us today. We are very excited to have Dr. Elissa Kozlov of the Rutgers School of Public Health with us to present her work recruiting older adults to mHealth Psychotherapy Studies. Before we jump in, if you have any questions throughout the presentation, feel free to unmute and ask during the talk. We'll also have a few moments at the end for Q&A as well. To get us started, I'm going to turn it over to Molly Nowles, Research Project Manager at the Center for Health Services Research here at Rutgers University, to introduce Dr. Kozlov. So Molly, over to you.
Great, thank you. So today, Dr. Elissa Kozlov will be presenting her talk, mHealth Psychotherapy Studies with Older Adults. Dr. Kozlov is a licensed clinical psychologist and assistant professor in the School of Public Health in the Department of Health Behavior, Society, and Policy. She's also the newly appointed director of the Population Aging Concentration in the School of Public Health. She is currently funded by a Beeson K76 award from the National Institute on Aging to conduct mHealth mindfulness therapy for older adults with serious illness and their caregivers in a dyadic pilot feasibility study. And without further ado, I'm going to hand it over to Dr. Kozlov.
Thank you, Molly, and thank you everyone for coming. I apologize in advance if I end up having to mute myself to have a coughing fit. It's the season, I guess. So I'm going to talk to you today about my mHealth mindfulness psychotherapy studies and some of the interesting challenges I've had working with older adults in this exciting area. So this work was supported both by a KL2 grant from the New Jersey Alliance for Clinical and Translational Sciences, or NJ-ACTS, and then also from a K76 Beeson Careers in Aging grant from National Institute on Aging. So I'm going to talk about two main studies, and then I'll give you a little sneak peek into my current Beeson K76 study as well. So while this first study, the reach, use, and impact of a free mHealth mindfulness app, is not a psychotherapy with older adults study, it is important background to understand the landscape of mHealth psychotherapy studies in general. And then I'll move into some of that feasibility and acceptability of the mHealth mindfulness study with older adult caregivers. And then I'll give you that sneak peek into what we're doing right now. So allow me to provide a little bit of background on mindfulness therapy. Mindfulness therapy is a behavioral intervention with preliminary evidence for managing stress, anxiety, depression, and other psychological symptoms. And mindfulness therapy uses psychoeducation, guided meditation, and some other targeted exercises to help individuals cultivate what we like to call a non-judgmental awareness of the present moment. The way that I think about mindfulness is it's this really crude, like an incredibly crude overview, but people who tend to think about the past are prone to some depression. People who tend to think a lot about the future are prone to some anxiety. We try to get people to be centered in the here and now, the present. That's where that mindfulness awareness of the present moment comes from. Traditional mindfulness therapy involves 8 or more sessions of face-to-face treatment with a trained provider, which is likely not a realistic treatment model for the general population due to the lack of availability of trained personnel, time constraints, reimbursement issues, patient and provider availability. All of this suggests that we really need to rethink how to deliver psychotherapy. We need an innovative delivery model such as mHealth in order to overcome some of these barriers to traditional psychotherapy. And there's actually a nice growing body of evidence that suggests that mHealth apps can effectively and feasibly deliver components of mental health interventions. So both of my studies, actually all 3 of the studies I'll be talking to you about today, utilize Mindfulness Coach, which is an mHealth app that was developed by the VA's Veterans Affairs National Center for PTSD Research. Mindfulness Coach is an iOS and Android-based app that's designed to deliver a mindfulness training course based on the adaptations of several different VA protocols. The app is totally free. You can download it right now on the Apple or the Play Store. And I want to walk you through Mindfulness Coach a little bit more for those who are unfamiliar. So this image right here is the home screen. You see 4 main areas. training, practice now, track progress, and build expertise, as well as this blank space up top. As you spend more time in the training section and complete levels, a tree starts to grow. So this will start to blossom with a beautiful little tree to sort of gamify psychotherapy. There are 14 training levels in total, each with education and exercises. So here's a more detailed look at some of the areas. You'll see that there's this opportunity to learn more about mindfulness and to set goals and take assessments, as well as to practice guided meditations and other exercises. So I want to talk about the first study, which looked at the reach, use, and impact of Mindfulness Coach in the general population. So a little bit of background here. Smartphone use at this point is fortunately or unfortunately fairly ubiquitous. So about 85% of Americans 18 and up now own a smartphone. And in that 18 to 49-year-old demographic, that percentage is more like 95 or 96%. If I had a little bit more time today, I'd probably say, let's do a quick poll and ask how many of you are currently within 2 feet of your cell phone. And my guess is that every single one of you would raise your hand. I would also ask everyone to estimate how many days or how many minutes in the day would you say that you are more than 2 feet away from your phone? And I'm guessing that most of us would probably say fewer than 2 hours. So this is kind of a blessing and a curse, right? Obviously for today, let's consider it a blessing because we're going to think about it as a tool to help us. Given how much of the population has access to smartphones, it's increasingly possible for these mental health apps to be disseminated for the public use, but very little is known about how these mobile mental health apps are really used outside of a controlled research design. So to that end, the goal of our first study, oh gosh, here we go. Okay, so the goal of our first study was to characterize the reach, the use, and the retention and impact of Mindfulness Coach on the general population. So to do this, we looked at anonymous download and mobile analytics data for all the unique Mindfulness Coach downloads from August of 2018 to April of 2019. We also looked at reviews from Mindfulness Coach in the app stores, as well as in-app assessments completed. So this data included 104,067 unique downloads split between Android and iOS. That should be 47.1 on the iOS slide, not 37.1. My bad. That math didn't add up, and that's why 47.1. So the app saw on average 6,720 downloads per month. And overall, people really reviewed the app favorably. Of course, there's some bias in who goes and reviews an app, but this is the data we had, so this is the data we're going to present. And here we looked at app use in a bunch of different ways. So first, we assessed the average time between first and final use of the app, which was about 4.1 weeks. We also looked at the number of unique visits to the app, which was 4.3 unique visits, but it had a really large standard deviation. So we'll also report the median, which was 2. We also looked at average minutes of use in the app, which was 16 minutes, with, again, a huge standard deviation of 63. And lastly, we looked at the percentage of people who use the app at least one time after the initial download day, which was just over half. So given the high variability and tendency for most users to just download the app and then never use it again, we wanted to learn a little bit more about the high engagement users. So this group was the top 10% of users who reached level 7 or higher. And those users use the app on average for 84 minutes. In this graph, you'll see the association between duration of app use and the various scales of the 5-facet mindfulness questionnaire short form, which is an in-app assessment that people can take on their mobile device. And you can see here that as minutes increase, so too do their FFMQ or 5-facet mindfulness questionnaire short forms. So indicating that more app use leads to higher levels of mindfulness mastery. So you'll see from the results that there was tremendous variability in the use patterns among people who just happened to download the app from the store. So again, these are just everyone who downloaded the app. We're not necessarily seeing this in a lab setting. This is, if you downloaded the app, you were included in this. Most users' natural inclination is to use the app infrequently and for a short period of time. And in fact, many users don't even make it past the home screen. However, we did find that there are users who found the app highly engaging, really used it a lot, and that increased use is associated with higher scores on the FFMQ. So this is really promising because at least for that high user group, which was 13,000 people, we're seeing that the app is really doing something to capture their attention. Okay, so we're going to move on to the second study unless someone has a question. I'm not monitoring the chat, so if there's questions in the chat, please speak up. Okay, so this next study was a more formal lab-based study to assess the feasibility, acceptability, and preliminary efficacy of Mindfulness Coach for caregivers of older adults with cognitive impairment. So for some background here, we know that caregiving is associated with many negative health outcomes, including increased level of stress, depression, and anxiety. And these risks are really especially high for caregivers of older adults with cognitive impairment. And while the patients tend to have many medical appointments, caregivers are often overlooked by the healthcare system because routine screens and treatments for caregivers are not really part of the primary care or specialty care centers that tend to care for older adults with cognitive impairment, even though we know that these health outcomes for the patient are tied to the well-being of the caregiver. We're really just not set up to manage the caregiver's concerns because their patient is always the primary patient. So we wanted to determine if mHealth mindfulness therapy might be a feasible and acceptable and preliminarily effective therapy for this population. And we understand that this is a population that in particular has some real challenges to accessing traditional psychotherapy, right? There's even more competing time demands on caregivers who are already very overburdened with their caregiving routines. A lot of times caregivers we call them the sandwich generation, which is people who are caring for their own children and for their adult parents. A lot of times they work full-time jobs and are also caregiving. So there's a lot of reasons why traditional one-on-one psychotherapy would not be a reasonable treatment modality for this population. So our hope was that mHealth therapy might be able to overcome some of the barriers of traditional face-to-face psychotherapy. So I should say that our initial plan was to recruit 60 caregivers from geriatric primary care clinics throughout New Jersey and assess them at 2, 4, and 8 weeks, as well as continuously monitoring their app use through Mindfulness Coach. This is not quite what ended up happening because we launched the study in November of 2019. So we ended up having to switch gears and recruit from kind of wherever we could, which included online support groups, community agencies, and senior centers. We always planned and were able to give the caregivers a brief 30-minute orientation on how to use the app, but initially we had planned to do that in person, and as the pandemic set in, we switched everything to be online. And the rationale behind why we wanted to give this orientation was that from our first study, right, that mindfulness coach in the wild study, we saw that only about half of the population made it past the home screen and used the app more than once. And so we wanted to see if we could enhance app usage by providing a little orientation on how to use the app and giving them some rationale for why they should use the app, as well as logistics on how and when to use the app. So we created this little 30-minute orientation to teach people about the best way to use the app. So we had a lot of different recruitment strategies initially, but obviously as our plan to go from a clinic-based recruitment switch to a online recruitment, this all kind of got thrown out. So we had a lot of challenges recruiting due to COVID-19. recruiting for this study, in some ways, I'd say that we kind of recruited for two different studies based off of our recruitment strategies. So, we started the study as a clinic-based study, and then we turned it to an all virtual study. That being said, we did complete the study. So I'll keep telling you about it, but I just include this slide to let you know that, we struggled, right? We struggled quite a bit with recruiting caregivers of older adults with cognitive impairment during the pandemic. Honestly, we're still struggling to recruit this population. And so I don't know if folks on this call also do research with difficult to access populations, but if you do, I want to stress that you are not alone. This has been challenging, and it's really led to us having to be really crafty and resourceful and creative in terms of thinking about how we recruit. So here is a slide to show you where we recruited from pre-COVID-19 and where our patients or where our participants came from. So these are different clinics in the RWJ Barnabas healthcare system, and this is a pretty big senior center down in Princeton. So before the pandemic set in, we were doing pretty well with our clinic-based recruitment. It really was looking pretty good. And then everything got shut down, we got kicked out, and we had to switch gears. So you'll see here, we really just attacked every virtual resource we could come up with. We started cold calling senior centers to see if they were doing anything during the pandemic to help their virtually, and if we could come and give talks to them. What ended up being the most lucrative is this New Jersey Department of Human Services flyer blast. So we reached out to New Jersey Department of Human Services. They have a really great division on aging there. And we told them about our study, and they said, we would love to offer this to our to the people that we serve. And sure enough, after they blasted our flyer around, we got a really nice bump in our recruitment, which led us to get our total of 60 people. So we ended up retaining 58 people by the end of the study. They were primarily female, which is representative of a primarily female informal caregiving workforce. Most of the caregivers were caregiving for their partner, and most provided on average 73 hours of care each week. Average age was 62, and about 2/3 of the caregivers lived or cohabitated with their care recipient. About 2/3 of the sample were white, and 1/3 were recruited pre-COVID-19 pandemic in person. This slide shows us the acceptability and usability data. As you can see, the vast majority of our participants found Mindfulness Coach to be useful, helpful, and they were satisfied. 85% said that they would recommend it to a friend. 82% indicated that they thought caregivers would all benefit from the app. And before the study, we had set the benchmark for acceptability as 75% or more, responding that they agreed or strongly agreed with these questions. So we were really happy to see that most of these items had 80% or more agreement. As for the feasibility, so the app was passively collecting their use data, which showed us how much and how often they were using the app. On average, participants used the app for a total of 3.5 hours, and most of them, and on average, achieved level 6 out of 14. 80% of the users used the app in the last week of the study, which was also a key marker for feasibility and acceptability and retention. There was a great deal of variability in how much users engaged with the app, but you'll notice that our averages were much higher in the lab than in the wild, and all of our standard deviations are much smaller. Here we modeled the effect of study week on psychological outcome, and we separated the pre and post-COVID data to ensure that those cohort effects were accounted for. At the end of the 8 weeks, there was a significant reduction between baseline and 8-week anxiety on the hospital anxiety and depression scale, anxiety subscale. There's also significant reductions in perceived stress. You'll also notice a downward trend in all of the measures, which is important because we were underpowered to detect change. So the directionality of data is important to consider here. And here again, we modeled the effect of hours spent using Mindfulness Coach on those psych outcomes, and you'll see really similar results. Significant reductions in psych symptoms as app use increased, though you do see a bit of a quadratic effect on some of these scales. Again, we were underpowered for this efficacy data, but the trends in the data are important for us to consider as we prepare for a fully powered trial. So this pilot demonstrated that caregivers of older adults with cognitive impairment found Mindfulness Coach feasible, acceptable, preliminarily effective. And we actually just got a notice that we're at a qualitative analysis of this study was accepted for review in the clinical gerontologist, or sorry, was accepted for publication in the clinical gerontologist. And that paper showed that really the caregivers enjoyed using the app. We were able to capture some stuff that wasn't captured in the quantitative data. For example, many of the caregivers reported that they stopped using the app because they had learned enough mindfulness skills, and they actually started to practice some of the mindfulness skills outside of the app. So our in-app data wasn't collecting how often they were actually using some of the mindfulness meditation skills that they had learned from the app. So we have to think more carefully about how to capture that data in future studies, because, the way that I think about this is in psychotherapy, I try to give, when I work with clients in face-to-face psychotherapy, my goal is that they no longer need to come and see me, that they learn the skills and tools and then apply them on their own. It looks like that was what's happening with Mindfulness Coach. They learn the skills and tools from the app. They no longer need the app. They don't open the app anymore. But that doesn't really look great in terms of the quantitative data we were collecting. So in conclusion, Mindfulness Coach was used a lot in the lab. So the use numbers were really high when we did the lab experiment with really very little additional effort. All we did was show them the app, how to use it, how to download it, give them a little bit of information about why they might want to use it. The whole thing took under 30 minutes, and then they were really just off to the races. There is a lot of potential here for using Mindfulness Coach or other mHealth apps as a supportive service. But of course, we need a little bit more research, which is why I was really excited to receive a K76. That's a Beeson Career and Aging K76 Development Award to study how mHealth might be useful to both patients and caregivers in a dyadic study. So the idea behind this study is based off of something my mom always told me growing up, which was, I'm only as happy as my least happy child. A little intense message to receive growing up, but nonetheless, it really impacted me because I built a career development 5-year study on this premise. So the idea is that, okay, we saw that our caregivers had some benefit from Mindfulness Coach, but in those qualitative interviews, we were also hearing people say, the person I care for is doing so poorly, it's hard to be doing well myself. And so with that in mind, we thought, well, let's see if we can give the dyad, so the patient and the caregiver, both access to Mindfulness Coach and hope to get that direct effect from each person receiving direct services, but also an indirect effect of, okay, my care partner is feeling better, so I'm feeling better, or my caregiver is feeling better, so I'm feeling better. So this is an RCT of mHealth mindfulness therapy compared to WebMD as the attention control. Patients with serious illness and their support people are being recruited. Originally, we were, again, only going to try to recruit from that geriatric primary care site, but we've been recruiting since April. And it hasn't been going particularly well. So we opened up the study to primary care, an outpatient PAL care practice at CINJ. We've been using Deepsix patient lists to reach out to people who have serious illness diagnoses, but that has also not been particularly fruitful, as you'll see. So as of November 22nd, we opened it up to do this more diffuse online virtual recruitment. We're also going through research match now, and we have plans to recruit from pulmonology, cardiology, subacute rehab, and the Department of Human Services again, and really as many places as we need. This is a really good example of, you think that you're writing a primary care grant, and then you get into primary care and you can't recruit people for any number of reasons. And so you just have to be crafty and creative and think outside the box to figure out how to get people into your study. So I want to show you a little bit about what I mean when I say that it's not going all recruitment wise. So here's our recruitment efforts to date. We have one dyad enrolled in our study. They're about halfway through the study. They're enjoying it. It's going well. When we were in the clinics, we have approached 83 different dyads, and you'll see all of the reasons why they did not end up enrolling in our study for various reasons. So that's the short blessed test. It's a cognitive test. So, you know, we've toyed with what to do about this, right? This is not great. One dyad since April of 2022. We've talked about, do we really need the support person? Can we let singles into the study? And normally I would say yes, because it feels pretty bad to exclude someone who doesn't have a partner. But I propose this as a career development award to study dyads and to learn dyadic data analysis. So I'm not ready to get rid of this criteria. We talked about lowering the baseline anxiety score, which is an eligibility criteria. But we really want to get preliminary efficacy data out of this. And in order to see shifts in anxiety, we need to make sure that baseline there is anxiety to see shifts on. So not quite ready to change this. Nothing we can really do about not being interested and not being contacted. So we ended up deciding to just increase our reach, just get more reps, try to get our denominator as high as possible, but high quality denominators. So we're hopeful that with our new strategies, which again includes online support groups, research match, new specialty clinics, a subacute rehab facility, we're going to reach out to that Department of Human Services connection again. We are hopeful that we will get more than one dyad. We're trying to get 80 total into the study. We're in year 2 of a 5-year grant, so I'm not sweating too much yet, although I don't love this slide. This is my least favorite slide in this talk. But
Elissa, could I ask a question?
Yeah, please.
About it's sort of a general question about recruiting for studies like this. This recruiting, would you say that this recruiting is all in non-help seeking populations that are not seeking help for specifically for issues of stress or mental health?
Yes.
So, and at the same time, we have this phenomenon going on in the society right now where there's an awful lot of people that acknowledge that their stress is too much for them and are help seeking, and there's not enough, literally not enough mental health resources to respond to them all. So I just wondered if there was any way to team up with clinical sites that might even have waiting lists or have a lot of people seeking counseling or psychotherapy for the stress, some of whom would happen to be caregivers just by the natural statistics of the thing. And if there's any way to include essentially help seeking, because you get the feeling from these responses that for whatever reasons, this wasn't a problem. You're introducing the idea of providing help to a population that wasn't actually seeking help. But if you could sort of do some recruitment among populations that are seeking help, then this would be a form of the help that could be tested.
Yeah, that's a great point. These are not traditionally help seeking. I will say that so it's the dyad, right? So patients with serious illness and their caregivers one of the reasons why I wanted this to be a primary care study was because of the lack of mental health resources traditionally available in primary care. I thought that this would be, people don't always go to primary care because of anxiety or stress or depression, but it's usually a pretty good spot to try to influence or try to infuse more resources. I'd be curious to see how many help seekers, like mental health help seekers, would fit the bill of the medical inclusion criteria here. So
Yeah,
I tried to
yeah.
Yeah, I tried to write this as almost like a palliative care grant, because palliative care needs to go beyond traditional specialty palliative care practices, and palliative care is supposed to be doing mental health care, but seldom has the resources to do that. So I thought about it as a primary palliative care grant. Can we get these folks who are so focused on managing their serious illness that they're probably neglecting their mental health, but can we get them easy access to mental health care? But
are some of these sites palliative care or hospice sites?
Yes, we have an outpatient pal care site, and we have VNA involved as well.
Well, certainly those people are under a lot of stress, and certainly some of them might be seeking
additional
that kind of help. But people have sort of their own particular ideas about what they need at a given time. So if there's any way to tap into people that have already identified that they have a need of some sort for counseling type or psychosocial type intervention, I mean, in a sense, the results are surprising, but the results are telling you something. And it's about what people are seeking. So, how does one respond creatively to that?
Yeah, no, that's really great advice. We'll definitely look into that. Thank you. Any other questions? Well, I'm just about at the end of the talk. My last slide is essentially that. Sorry, forgot about the Deepsix. So I don't know if folks are familiar with Deepsix. It's a new tool offered by the Clinical Trials Office, where they can cull the medical records or the Epic charts and get you patient lists. We've actually stopped doing Deepsix recruitment because it was completely ineffective, but we were getting lists of people who had been through the Barnabas healthcare system, primarily through the inpatient hospital setting, who had one of 4 serious illness diagnoses: CHF, ESRD, stage 3 or 4 cancer, and COPD. So we were kind of just cold contacting them, but it was not lucrative. Most of them did not even let us screen them. Most of them we couldn't reach, and most of them we did reach were not interested. So we've given up on that. It was a very time-consuming and not at all lucrative attempt at recruitment. So all this to say that in terms of special populations, research with patients with serious illness is incredibly hard. Research with dyads is incredibly hard. Dyadic research with patients with serious illness is a total nightmare. I think I should have anticipated this more. I'm learning. Luckily, it's a K award. It's developmental. So I'm learning. I'm trying to figure it out. I've talked to mentors and colleagues in the field who are like, yeah, you really went for it. You really went for the hardest to reach populations, which I did not realize I was doing when I wrote the grant. I was following the science. My science led me to this grant. I went for it, and now I'm paying the cost, but I'm not giving up. I have many more recruitment avenues to try. So we'll keep pushing. We'll keep persevering, but it's hard. It's really hard. Doing primary data collection is hard. And when you make it primary data collection with an already sick, burdened, overwhelmed population, it's really tricky. So for those of you out there who might be in similar places, just know that you are not alone. It's hard. We'll get creative. We'll figure it out. So I will stop now. and open it up to a discussion, I guess.
Sure. This is Jim here from CHSR, and I'm just following up on a question that was asked in the chat box. Did you, or were you able to ask the folks who indicated that they were not interested when you did the Deepsix recruitment as to why they were not interested, or was it just not interested in a no?
So we added that question after a little while. We don't have it on everyone, to be honest. This is not going to sound great. I apologize. A lot of them had negative experiences at Barnabas and didn't want to have anything to do with anyone from Barnabas. A lot of them, the Deepsix query was not particularly specific. So we also had people who had been hospitalized 2 or 3 years ago. So we weren't able to narrow that time gap. So for some of them, the patients had died. For some, it wasn't relevant. It was not for because we wanted really inclusive sampling. So I was not particularly prescriptive in terms of what we were looking for with the Deepsix group. And I think we just had we didn't have a great patient list as a result. So yeah, it's a good question. Thank you for asking.
Does anybody else have any questions or discussion points to just discuss this critical issue?
Well, just to kind of keep the conversation going a little bit while other people think of their thoughts, and it's kind of related to my thought before. Do you think it's important that this participation, this intervention, be tested and conceived as something that is stands on its own as opposed to being part of, let's say, a psychotherapeutic type of intervention? Because I'm thinking again about the sort of, how people perceive the value, and whether, for example, there might be therapists out there or programs or counselors out there who might see it as a useful adjunct to what they're doing with their patients that could be offered to them. And that gives you sort of a highly credible salesperson if they perceive it as a useful adjunct. So would that interfere with your science?
It would. So the mHealth suite that the VA developed a lot of it is intended to be used in conjunction with a therapist. Mindfulness Coach is one of the ones that actually can operate as a standalone intervention without therapist assistance. I think you're totally right. I think that this app, I use this app in my own clinical practice with some frequency because I think it's a really effective and efficient way to teach mindfulness therapy skills. And if I don't need to spend my session doing that, all the better. For this particular grant, the premise of this is based off of the mental health clinician shortage, in particular, the lack of mental health care in palliative care, the lack of mental health care available for patients with serious illness and caregivers. So adding in a clinician component feels a little antithetical to the premise that there aren't enough clinicians and we need to think innovatively. I mean, I get that, like, if we use this,
if you want a rhetorical case that or a thought experiment, one could consider the thought experiment that what we need is ways to maximally extend the impact of the therapists that are out there, because all of them would like to be able to see their patients more often. All of them would like to be able to have more visits with their patients. Oftentimes insurance might limit them to some number like 10. So maybe not for this project, but for follow-on projects, if it could be conceived that way, you might find a little bit more of a convergence between people's perceptions of what they're seeking and your recruitment efforts.
Yeah, I agree. I think that that's a great avenue for the next study. I agree. Doreen,
Thanks. Yeah, we have a question from Dorina. Sorry.
Hi, thanks, Elissa. So kind of two thoughts. I think it's interesting what the findings that you have about using the Deepsix, because as you know, that's something that I'm just about to start using. And I had the similar concerns, right, in terms of like not targeting the right folks, and the fact that you were using a list from acute inpatient facility, right, who may have been in the hospital for a totally different reason. So do you recommend ways that we can work with the NGX, like in terms of improving that process? Because I know there's been some investment into it, and I don't know if you have any thoughts about that. And then the second question I had for you was regarding the whole dyadic approach, because as you know, the NIA is quite, focused on dyadic approaches, and that science is expanding. But I think we're also seeing a shift in the lack of caregivers, right? Most people aging in place by themselves. So do you see it as kind of as a conflicting scientific area? And so any ways that, approaches we can think about, like looking at that?
okay, let's talk about Deepsix first. They know that it's not great yet. It will get better. It will get better and better. Part of the issue is that the Deepsix rollout and Epic rollout were co-occurring. And if anyone is here who knows this better than I do, please correct me if I'm getting it wrong. I think part of the issue is that Deepsix was culling from the main hospital and not from the outpatient clinics. If they were culling from the outpatient clinics, we could have been more specific, but they didn't have the capabilities yet. All of this is yet, right? I couldn't say to them, give me all the Monroe and Monmouth South and and Monmouth outpatient geriatric clinics that had patients over 65, right? I couldn't say, here's who I want, because they weren't able to do location specifics yet. I think that they hope to be able to do that more and more as they get more sophisticated. I was one of the very first non-pharma clinical trials to request Deepsix access, and frankly, it's just not there yet. I've been a little bit vocal, maybe squeaky at times, that a lot of the clinical trials tools just don't feel like they're developed for behavioral interventions. They feel very, very geared to medical and pharmaceutical interventions. I don't know what's going to happen, but I know that everything that I've been told is that they're building it for the money right now, and then maybe down the road the behavioralists will be able to cultivate it better. But right now, even with Epic, everything's a slow rollout. It's just not there for behavioral scientists yet. It's just not that useful for us yet. They know. My hope is that they will fix it for us when they can. Your second question, let me see if I remember. Dyadic stuff. Wait, say your second question again.
Oh, no, that's okay. No, I think you alluded to the trend that, a good proportion of your those who were not interested or not able didn't have a caregiver. And so, at least from my perspective, from what I've read, I think we're going to see a higher number of people aging in place by themselves. But there's this push, right? There's this sort of science, what you alluded to, a need to study dyadic approaches as well as have interventions that target both. So do you see that as kind of, something to overcome?
Here's what I would do if I was starting from scratch. If this weren't a K award, I would make dyadic involvement optional. But because this is a K award with a limited budget, a limited sample size, and specific training aims, the dyadic part for me, for now, I'll talk to my PO maybe next year, but for now, it's a little bit of a non-negotiable, because how do I say that I'm learning dyadic data analysis if I don't have dyadic data to analyze? I would say that if I was crafting this as an R01, I would make dyadic involvement optional, because the idea of excluding someone who doesn't have a dyad feels morally dubious, right? Arguably, these are the people who need the most support, not they shouldn't be. There's no reason why they should be screened out of my study, except that my study is a training grant, not, a full-blown powered efficacy grant. I don't know how that will translate down the road in terms of like, you know, you would have to think about how that affects your statistical power if you have some dyads and some not. But I think that what we're also seeing from NIA is a push for caregivers. So I think that push for dyadic research is actually partially a push to include caregivers in the process, because caregivers have been neglected for decades. We know there's so many caregiver studies out there, and so few of them have efficacy, right? Like we still have no idea how to actually help caregivers in a way that's feasible and meaningful. The REACH studies were our best bet, but those aren't, who can implement the REACH study in real life, right? Like those are multimodal, multifaceted interventions. If there's gerontologists on here, you know what I'm talking about. But the REACH study essentially was like psychoed, support, therapy, education about symptom flare. It's just really big studies. So I think that dyadic push from NIA is them saying we know that we haven't managed caregivers well, and we're trying to do better.
I have another question that might tie into the recruitment. And again, this is probably more a question about potential future studies than it is about the current study. But the current study is premised on family caregivers.
Informal.
So just as a thought experiment, how would the whole concept change if you included paid caregivers?
So interesting that you bring that up. There's a competing talk right now by a woman visiting from Cornell named Maddie Sterling, who's being interviewed as a candidate in internal medicine. And all of Maddie's work is in how to support and how to improve the paid caregiver experience. So she has a lot of really impressive collaborations with VNA NYC. And she and I have started talking about collaborations where we infuse some of my work with mHealth resources for informal caregivers with her work with how to best support formal or paid caregivers. So that work, she actually just received a Doris Duke Foundation grant to improve the mental health and well-being of paid caregivers. And I'm a consultant on that grant, and there is a mindfulness component to that as well. So that is on our radar.
I love that because, I did this qualitative work many years ago with paid caregivers in New York. And I actually, for bureaucratic reasons, ended up with a couple of dozen of the senior homemakers that had been originally primary providers and eventually became trainers. So I got to know a lot of these people, and you talk about stress.
Oh, it's the worst. Maddie just put out a paper, I think I'm a co-author on it, about their depression levels, anxiety, stress, burnout, and all of these outcomes have downstream effects for the patients, right?
Exactly.
When these caregivers burn out and they quit, then there's lack of continuity of care in terms of care for the patient. So you should look up her work. She's pretty brilliant. She's really great. We're trying to get her at Rutgers through internal medicine.
That's great. And the other thing is that we think naturally of because it's kind of a bureaucratic distinction in the healthcare system. It's like two different things. A family caregiver, but if you look at the kinds of relationships that actually develop with somebody who's in your home all day long, exactly, they have many of the same affective and interpersonal characteristics as as a couple or other family caregiving. And just recently we went to the funeral of a neighbor, and of course the home attendants were there. So those relationships are very complex and interesting, with many stresses and many positive features, but really understudied.
Yeah. Yep. I couldn't agree more. I'm hopeful that we can get Maddie at Rutgers to make our collaborations a little easier. Karen?
Yeah, hi, Elissa. Very interesting topic and presentation. And I'm just curious to know if you would ever consider expanding recruitment to outside of the primary care units and include psychiatry. Because so often, from my experience, I've seen adults caring for adult children in their home, and the level of stress they experience is inordinate. And with those recruited individuals, you could then also try to expand to NAMI and some of the larger mental health organizations that support adults who are the caregivers of those with mental illness.
That's a great suggestion. Thank you. So right now, the inclusion criteria for the patient is that they have to have serious medical illness, but SMI is also really important. And I think it's just a slightly different population. So probably a different grant, but one that should certainly be.
Yeah. I mean, because in my work with some clinical individuals, it's just the stressors among these adults caring for their adult children is really incredible.
Yeah, I almost wonder, I would think that mindfulness might not be the best fit because there's so much more going on there too. There would need to be quite a bit of psychoeducation about, the specific SMI that their patient, right? Like I wonder if it wouldn't be a robust enough intervention for that population.
It's a huge discussion among in meditation centers and so forth as to what we can responsibly do with people with serious mental illness, and different different centers and different abbots and different leaders have had different ideas about this, and the common thinking. The thinking from Plum Village, for example, was that you could include a certain number of people if you had really the right facilitators, but that you have to proceed carefully, because you can open up a lot of material that sometimes people you go beyond that require a professional to deal with. So it's a big question.
Yeah, I mean, I think what everyone is sort of hitting on is that we know that there's a mental health professional shortage, and it's a crisis because of how big the mental health crisis is in this country. So we really have to think about innovative strategies to extend the use of the existing mental health workforce, to expand who we're able to reach and access, to make mental health care as easy and ubiquitous and destigmatized as any other type of healthcare. So I think, when it comes, I don't think mHealth, look, from these studies, I'm not here to say that mHealth is the answer. It's not the answer, but I think that mHealth in a stepped care model, or mHealth as a first line defense, might knock out a lot of people who would be otherwise seeing one-on-one psychotherapists and don't need to be. And then that might free up the psychotherapists to then see patients who don't respond to mHealth. So I really believe in stepped care, and I really believe in innovation around mental health care delivery, whether it's for, parents of patients with serious mental illness, or patients with serious illness who have competing medical appointments and fatigue and burden that prevents them from structured one-on-one, right? There's so many different reasons why face-to-face psychotherapy might not work for any given person. I just think that we need better mHealth research, because right now if you just Google best mHealth app for depression, you'll get a bunch of hooey. Like, it's just not great. There are some apps out there that are strong and have evidence-based, but you're not going to stumble onto them necessarily. You're going to get Headspace and Calm, and those are fine. They're fine, but they're not going to work for everyone. And they're expensive. They're actually kind of pricey. So we just need to think more critically, I think, about how mHealth mental health is utilized, disseminated, integrated into existing care structures, et cetera.
Elissa, have you thought about, kind of going back to recruitment, have you thought about trying to recruit in faith communities? I'm thinking faith leaders may have a really good gauge on who in their communities might fit your
Not
criteria.
yet, but I'll definitely do that when these next. So I just unleashed my next round of recruitment strategies. So we're going to start in pulmonology this week, and Research Match and all these online communities. When those inevitably dry up and or fail, that's my next option. Thank you, Molly.
Yeah, it's a great idea, Molly. And I wonder if working through faith communities and connecting to patients that way would also help with some of the stigma against mental health care, when your pastor or deacon is the one communicating with you about your needs.
Thank you all for this really lively discussion.
Yeah, it's been great. Does anyone have any kind of final thoughts? We got a few minutes left, so that we can still continue for a bit. Hearing none, I think we're just going to thank Dr. Kozlov for this presentation. It was incredible. Just a really fascinating look at a real vulnerable population that I think really fits in line with what we're trying to do here with our NJ Acts webinars. Really appreciate it, and a lot of good practice information about recruiting. And thank you everyone for attending and for participating in the discussion, and we will see you shortly.